In patients with liver cirrhosis who are negative for hepatitis B and C infections, the use of adalimumab, a TNF alpha inhibitor, warrants careful consideration due to the potential risks associated with immunosuppression and liver function impairment. Key considerations: 1. Immunosuppression. Adalimumab suppresses the immune system, which can increase the risk of infections, including bacterial, viral, and fungal infections. Patients with liver cirrhosis are already at higher risk for infections due to impaired immune function. 2. Liver function. Although adalimumab is not primarily hepatotoxic, liver cirrhosis can alter the metabolism of drugs, potentially leading to altered pharmacokinetics and increased toxicity. Close monitoring of liver enzymes and liver function is necessary. Risk of complications. Patients with cirrhosis are at increased risk for complications such as spontaneous bacterial peritonitis, variceal bleeding, and hepatic encephalopathy. The use of adalimumab could potentially exacerbate these risks. 4. Clinical data. Limited data is available specifically addressing the safety of adalimumab in cirrhotic patients. Some case reports and small series suggest that biologics can be used with caution in selected patients with well-compensated cirrhosis, but the data are not robust. 5. Alternative therapies. In patients with significant liver disease, the risks and benefits of continuing TNF-alpha inhibitors like adalimumab should be weighed against other treatment options, including non-biologic DMARDs or alternative biologic agents with potentially less immunosuppressive effects. Multidisciplinary approach. Involve a hepatologist in the decision-making process. Regular monitoring of liver function tests and vigilance for signs of infection or hepatic decompensation. Patient selection. Adalimumab may be more appropriate in patients with compensated cirrhosis, Child-Pugh class A, while it might be avoided in those with more advanced liver disease, class B or C. Decisions regarding the use of adalimumab should be personalized, taking into account the severity of the liver disease, the underlying rheumatologic condition, and alternative treatment options. Cyclophosphamide, an alkylating agent used in severe autoimmune diseases, also presents significant risks in patients with liver cirrhosis. The safety of cyclophosphamide in such patients requires careful evaluation, as it comes with its own set of challenges. Key considerations. 1. Hepatotoxicity. Cyclophosphamide itself has the potential for hepatotoxicity, which can complicate existing liver dysfunction. It can cause elevated liver enzymes and, in rare cases, veno-occlusive disease, hepatic sinusoidal obstruction syndrome, particularly in patients with compromised liver function. 2. Metabolism and excretion. Cyclophosphamide is metabolized by the liver through cytochrome P450 enzymes and excreted by the kidneys. In patients with liver cirrhosis, impaired liver metabolism can lead to altered drug clearance and increased risk of toxicity. Dose adjustments may be necessary. 3. Immunosuppression. Similar to adalimumab, cyclophosphamide is a potent immunosuppressant, increasing the risk of infections, which is a significant concern in cirrhotic patients who are already immunocompromised due to their liver disease. 4. 4. Bone marrow suppression. Cyclophosphamide can cause myelosuppression, leading to leukopenia, anemia, and thrombocytopenia. In patients with liver cirrhosis who may already have coagulopathy and thrombocytopenia, this risk is particularly concerning. 5. Renal impairment. Cyclophosphamide's active metabolites are renally excreted, and in patients with liver cirrhosis, concomitant renal dysfunction, hepatorenal syndrome may further complicate the drug's safety profile. 6. Comparative safety. While both adalimumab and cyclophosphamide carry significant risks, the choice between them depends on the severity of the rheumatologic disease and the patient's liver function. Cyclophosphamide may be more appropriate in life-threatening rheumatologic conditions, e.g. vasculitis or rapidly progressive glomerulonephritis, but this must be weighed against its potential for causing significant toxicity. Recommendations: close monitoring. Frequent liver function tests, blood counts, and renal function assessments are crucial if cyclophosphamide is used. Dose adjustments. Consider lowering the dose or increasing the interval between doses in patients with cirrhosis to mitigate potential toxicity. Patient selection. Reserve cyclophosphamide for patients with severe life-threatening autoimmune diseases and where alternative therapies are not viable options. Multidisciplinary management. Collaboration with hepatology and nephrology is essential for optimizing patient safety. Given the risks, cyclophosphamide may not necessarily be safer than adalimumab in patients with liver cirrhosis, and its use should be considered very cautiously. Each case needs to be individualized based on the severity of the liver disease and the rheumatologic condition being treated. If the liver function tests are normal in a patient with liver cirrhosis, the risk profile for both adalimumab and cyclophosphamide may be more favorable. However, the underlying liver cirrhosis still presents potential challenges. Here's a refined approach to managing such a patient. Hatch adalimumab in cirrhotic patients with normal liver function. 1. Lower risk but still caution. Normal liver function tests are reassuring, but cirrhosis can still affect drug metabolism. Even with normal tests, the potential for future liver decompensation remains. Careful monitoring is essential. 2. Infection risk. Adalimumab's immunosuppressive effects remain a concern, so vigilance for infections and regular monitoring are required. 3. Use in compensated cirrhosis. If the patient has compensated cirrhosis, Child-Pugh class A, adalimumab can be used with caution. However, close monitoring of liver function and signs of hepatic decompensation should be maintained. Cyclophosphamide in cirrhotic patients with normal liver function. 1. Dose adjustments. Even with normal liver function, dose adjustments or extended intervals between doses may still be warranted to avoid potential cumulative toxicity, given that cirrhosis can unpredictably worsen over time. 2. Monitoring. Similar to adalimumab, regular liver function tests, complete blood counts, and renal function tests are necessary. Bone marrow suppression and hepatotoxicity can occur even in patients with normal baseline liver function. 3. Indication-specific. Cyclophosphamide should still be reserved for severe or life-threatening rheumatologic conditions where its potent immunosuppressive effects are justified. General approach. 1. Multidisciplinary management involving a hepatologist remains crucial even with normal liver function to monitor for any signs of liver disease progression. 2. Regular monitoring. Regular liver function tests, along with other relevant labs, CBC, renal function, should be part of the management plan regardless of the chosen medication. 3. Patient counseling. Inform the patient about the potential risks and signs of liver decompensation or infections and emphasize the importance of regular follow-up. Decision making. Adalimumab may be considered in a patient with normal liver function, especially in cases of inflammatory arthritis or other indications where TNF inhibitors are beneficial. Regular monitoring is key. Cyclophosphamide should be used more cautiously, even with normal liver function, and typically reserved for severe life-threatening conditions such as systemic vasculitis or severe lupus. In summary, in a patient with liver cirrhosis but normal liver function tests, adalimumab may be a safer option compared to cyclophosphamide, particularly for chronic rheumatic diseases, but both medications require close monitoring and individualized decision-making.